a kind of broad network that was created in 2011 from NINDS to kind of test new therapies, increase the efficiency of clinical trials. I think one of the, as I understand it, one of the goals in putting that together was kind of historically in neurology, I mean other fields as well, but particularly in neurology, there were a lot of phase 3 clinical trials that were not finding significant results when the phase 2 studies looked promising, but some of that was because of the rigor of phase 2 studies may not have been what they needed to be. And so one of the things with NeuroNEXT that we were tasked to do in the original announcement we were funded was to help design phase 2 clinical trials that had kind of strong go, no-go criteria. And I think the big focus is really on the no-go side. I think it's easy to have go, but there are many instances, if you look back at a lot of areas that failed where the phase 2 trials were kind of set up where they couldn't fail. And so you kind of already decided to go to phase 3, and there was really nothing in the phase 2 that would tell you not to go forward. And so the no-go is equally important. And one of the things that as statisticians we like to say is that a well-designed, whether it's phase 1, phase 2, phase 3 clinical trial, a well-designed clinical trial that gives you evidence that an intervention doesn't work is not a failed trial, that's a successful trial. The only kind of failed trials would be one where the design was inadequate to really get an answer, so you get to the end of the study and you can't really tell whether the drug works or doesn't work because of flaws in the design. So as long as you set this up, and the sad truth, I was once told years ago, biostatisticians are the killjoy in a room of clinicians. But I mean, in all honesty, if half of your proposals led to things that work, that would be amazing, right? And it would be well above the average in neurology, right? And that's just kind of the general truth. And so as biostatisticians, we work with a lot of colleagues who have these great ideas and promising data, and kind of it's our job to help design the studies, to help kind of determine, right, is this real, is this problematic, is this worth going forward. One of the things in NeuroNEXT that's I think both a strength and a challenge of the network is, unlike a lot of other consortiums or working groups or networks, it's not disease centric. It really covers anything under the NINDS umbrella that doesn't fall into like StrokeNet and Siren. So we have a wide range of diseases that we work on, which you'll see as I go through this a little bit. This is a list of our current sites. We're on our 3rd iteration. So some of these sites have been with us since the beginning, and then through the 1st, 2nd, 3rd, we've had some sites who have come on and fallen off, others who have joined later. So we're currently, as of today, at 14 sites. The other thing that I will mention, this is a common misconception, I think in NeuroNEXT, but also perhaps in some of the other networks. You do not have to be at a network site to submit a network proposal. So some of you are at network sites, some of you are not, but if you have a good idea, now or in the future for something that would be a good phase 2 study for NeuroNEXT, you should consider discussions with NINDS about applying. And if you're not at a network site and you apply and are accepted into the network to submit a grant application, then your site becomes a site for that study. So that's not a limiting factor. The other thing to mention, which I think this is also true for StrokeNet and Siren, none of the networks have dedicated funds available for studies. The funding from NINDS for the networks is infrastructure, and each individual proposal comes in, works with the networks to draft a proposal that is submitted as an application that goes through review and so forth and is funded for that individual study. So whether it's network or not network, your study is going to be reviewed and judged based on its merit from external reviewers. We transitioned in this 3rd iteration to OTA, or Other Transaction Authority. This is, Clint can give more details of this probably than I can, but it's a more flexible arrangement, both in terms of how NINDS can work with investigators, but also the timeliness of review, because it can be reviewed kind of on a rolling cycle. So it decreases some of the white space, in that if you submit a grant, you have to wait for review, and then you have to wait till you can resubmit and so forth. This is supposed to condense that, but it's a 2-stage process where really the network gets involved in stage 2, where stage 1 is kind of a quick, high-level review. I mean, there's information you have to supply, but the stage 1 review is basically reviewing like the science, the concept of what you're proposing. And so if something is just not aligned with priorities, or it's not deemed to be important, it would never get forward. If it passes stage 1, then in preparation for stage 2, that's where you would flesh out more of a typical grant application, statistical analysis plan, protocol, and so forth, kind of the full kit and caboodle that would be submitted. And if it passes stage 2, then it would be funded and moving forward. We're still in the relatively early phases of this. We've had the first kind of grants go all the way through to stage 2, so we're still learning it, from the network, because this has been a transition. I mentioned anyone can apply the areas. So mostly what we do in NeuroNEXT is phase 2 clinical trials. That's what I will focus on today, which is kind of in line with where many of you either are or are going with your research. You're looking for adult, but there's also an emphasis on pediatric studies. We've had more adult proposals than pediatric proposals, but we're trying to encourage pediatric proposals within the network. We also, since the beginning, have done biomarker studies, particularly biomarker validation studies. We've done 2 in the network so far, looking for biomarker ideas as well. And then also part of the renewal for this cycle, we are partnering with Urgent, which is kind of a preclinical gene therapy consortium to do kind of phase 1 early phase gene therapy studies. And so we've had a few proposals come through with that, which are kind of a very different animal than one I'm going to talk about today. So what I really want to focus on here, and I'm going to talk about a few designs that we've done in NeuroNEXT, particularly to give you some real life examples. This is by no means thought to be like the most popular phase 2 designs or all of the phase 2 designs that you could consider. There are many different options out there. One of the things that I think I have a better appreciation of, having been involved in NeuroNEXT now for, 14 years, is in many ways, I think phase 2 clinical trials are the hardest to design. If you've done everything well in phase 1, phase 2, designing the phase 3, it's not easy, but it's not that difficult. It should be pretty clear where to go. Phase 2 are tough in that you're not trying to show efficacy. That's what you would do in phase 3, but you're trying to get enough of a hint of efficacy to tell you whether it's worth going to phase 3. You're not really trying to show safety, but you're trying to get enough of a hint of safety. And what you're really looking for is the risk-benefit profile at least okay to go forward, and is there enough evidence to go forward to phase 3? And that's kind of a difficult teeter-totter to motivate around, particularly in different diseases. And so that's a lot of what we focused on in a lot of our design discussions in NeuroNEXT. And really, it's this whole proof of concept, the risk-benefit profile. Sometimes type 1, type 2 errors may be different in phase 2 clinical trials. There's also one of the things I also have appreciated more in recent years is this is probably the one area of clinical trials where academic clinical trials and industry clinical trials differ the most, in that, especially with some of the emphasis with the strict go, no-go criteria, I think the rigor at which you have go, like to meet a success to go to phase 3, is often higher in academic trials than it might be in industry trials. Part of that is a difference in culture. In industry trials, each clinical trial is part of a large program that has a clear sense of where it fits in, and the evidence is all put together and part of that. Whereas in academic trials, we don't have that sense as much. But also it comes down to who is at risk for the subsequent study, right? If a company wants to design a trial with whatever rigor they want, that's part of a larger program, and they're going to pay to take it to phase 3, it's their risk if it goes forward to phase 3 based on different levels of information. If you're talking about academic trials where the phase 3 will be funded through NIH, where it's taxpayer funded, that's a whole different animal. And often there's a higher bar because the risk there is not a company, it's the taxpayer dollars and NIH, and especially in environments where NIH dollars are precious. You want to make sure that you're investing those dollars in studies that are likely to be successful or have a high chance of being successful, and that's where maybe a slightly higher bar to go forward may be there. That's not always the case, but I think that's one area where, at least when we work with companies in NeuroNEXT, sometimes the design that we need to get funded through NIH and the design that the company wants are not always aligned, often for that reason in terms of what is the threshold to go forward. We mentioned this go, no-go criteria. That's where a lot of our discussions take place. And I think a lot of studies, if you look in the past, you have these vague things, and I still see this with investigators, where the go criteria would be if the treatment shows a trend towards benefit. Statements like that are very ambiguous. I've worked with clinicians long enough to know that you guys are good at two things. explaining why something you think works didn't work, and explaining why something unexpectedly works, right? You could come up with explanations after the fact. For most of you, you're dedicated to what you're studying. You could look at data and see a trend. Someone who doesn't think what you're doing works could look at the same data and see no trend. And so when you don't have kind of rigorous criteria, it's kind of become somewhat subjective. And that's, if you think it works, you're going to see data most likely that thinks it works, unless it's a complete dud, which is seldom the case. If you don't think it's worked, you're going to look at data and think it doesn't work. And so a lot of the discussions that we have is, okay, what does that mean? What level of trend do you want to see, and how do you put rigor into doing that? There are also examples that I've seen where, and this is a struggle I know many of you have had, where in early phases it's not clear what endpoint to use. And so you might want to look at several endpoints. I've seen people come to us with phase 3 trials where they want to look at 5 different endpoints. And they say, we want to go to phase 3 if any of the endpoints show a trend towards significance. You don't need a statistician for that study, right? The chance that you don't see a, quote, trend on any of 5 endpoints, even if the drug doesn't work, is pretty small. And so those are examples of what I said earlier, when in some ways the design can't fail. And so one of the questions I think that we force investigators to ask when we're talking about design is, can it fail to go forward? What criteria would you have to meet for it not to go forward? And if there's really no way it can fail, then it's probably not a good design, because it's not really telling you that the drug works or not. You're really just doing it to get data to plan your phase 3 trial, which you're already going to, which then may or may not succeed based on what evidence that you talked about. So a lot of time is spent in that. Other common errors, we've got some of these, but basically there's this time struggle. And that if you think it works, and Roger talked about equipoise, right? There's kind of 2 levels of equipoise. None of you have what you would call equipoise. You're convinced that your intervention has a high chance of working, or you wouldn't be dedicating your time to doing it. But the idea of equipoise in clinical trials is not everyone might agree with that, right? And so you want to make sure, if you believe it works, you want to get to phase 3 as quickly as possible. But if you don't have all your ducks in a row when you go to phase 3, you have chances that even if your intervention is successful, you might not be successful in phase 3 because you've chosen the wrong dose, or you've chosen the wrong endpoint, or some other reason. So there's this trade-off between what do you need to know for phase 3 and what you can get from phase 2, and getting to phase 3 as quickly as possible. The one thing that I will tell you do not do, and I think many others in this room who have been on study sections will concur, if you submit a phase 2, or at least this has traditionally been the case, if you submit a phase 2 clinical trial that is basically an underpowered phase 3, so it's a study you want to do for phase 3, just half or a third of the sample size, that is the kiss of death in study section, right? Once the words underpowered phase 3 trial come up in study sections, it like sucks the air out of the room. So you want to avoid that. You do not want to have an underpowered phase 3 trial as your phase 2 clinical trial. Study sections are fascinating social experiments, and study sections where those words come up, it's not good. Valerie, do you agree with that? Yeah, we've all had experiences from that. All right, so now I'm going to talk about a few phase 2 clinical trial designs that we've used. These are just examples of studies we've implemented. Some are more rigorous than others, but they've all served their purpose. The first is a simple one, like a safety tolerability design. And one of the caveats I'll say here, if you're in phase 1, you're in phase 2, or you're in phase 3, regardless, your aim should never be, I want to confirm that the drug is safe. You can't do that, right? When you talk about safety as an objective, as you go from phase 1 to phase 2, phase 3, what you're really talking about is you're not showing the drug is safe. There are approved drugs that may have, may be unsafe. That's why we do post-marketing follow-up, because they're safe in the population you might have for clinical trials, but when you get into millions and millions of people, you might see rare side effects. What we're rolling out at each level is varying degrees of unsafe, right? And so as you progress forward, you can determine the drug meets an adequate level of safety to go forward, but it doesn't tell you that the drug is safe. But in many studies where you're looking at a different population or it's early, you might want to know, is the drug safe? And is it tolerable based on some pre-specified criteria? We did a study, this was in partnership with a company called Azavan, looking at an intervention, SRX246, in Huntington's disease, looking at irritable subjects with symptomatic Huntington's disease. this is kind of a side story. I tend to do this sometimes when I talk, but the two things that got me through my dissertation was WWE and Jerry Springer. I'm dead serious about that. But this had one of the best animal models that I've ever seen in my life. It was basically Jerry Springer, the Jerry Springer of animal models. The animal model for this was based on you put a male and a female mouse in a cage together, and so they kind of mate and get around. Then you take the male out, and you put another male in. And then after a while, and then you put the other male in, and the two males fight over the female. It's a Jerry Springer episode in a mouse model. It has nothing to do with the design, but I thought it was funny. So anyway, but the main point of this was adequate safety, but also tolerability. Can people take the drug for a period of time? If people can't tolerate the drug, then it's not going to be feasible for a phase 3 clinical trial. So for this one, we looked, the GO criteria was actually a non-inferiority test based on this criteria of whether you had like worse than a 50% rate of tolerability or adverse events on drug relative placebo. So it's actually a pretty low bar to pass, but it was important to pass to know that it was suitable to move forward to. In this case, would be a later phase 2 design, not a phase 3, which it actually met the GO criteria. It was safe and tolerated. The company has advanced that into later phase 2 trials. That's a relatively simple design. Others are like surrogate endpoint designs. And these are ones that would be more popular if we just had better surrogate endpoints. There aren't a lot of good validated surrogate endpoints. There's a lot of work to develop those. As we get more, this will be more popular. This was based on one that we did do in the early days of NeuroNEXT with Bob Fox, an investigator at Cleveland Clinic, looking at multiple sclerosis, primary and secondary progressive MS, where brain parenchymal fraction, or basically a measure of brain shrinkage, based on imaging, was used as a surrogate endpoint in place of the clinical endpoint. The whole idea of the surrogate endpoint in these phase 2 clinical trials is it's something you can measure more quickly. And so with fewer patients or shorter time, you can get a hint of signal on the surrogate endpoint with the hope that if you meet the significance on the surrogate endpoint, then a future phase 3 trial, larger, more subjects, longer period of time on the clinical endpoint might be successful, right? And that's why it's important to have good surrogates, because unless the surrogate is a good surrogate of the clinical endpoint, it's not going to be that predictive. In this case, it was thought to be a pretty good surrogate. So the brain parenchymal fraction was measured longitudinally with that, and you can see kind of the result on the left here is the drug versus placebo effect, where the drug slowed the rate of brain atrophy by 50%, so it was a significant slowing. But more important, if you looked at the clinical endpoint, it showed a non-significant, but a trend that was trending in the same direction. So you kind of had the GO criteria with supportive evidence here. It met the GO criteria, was statistically significant on the primary endpoint of the surrogate endpoint, but it also had at least a, quote, trend, and I know I mentioned the problems with that term before, but in this case, the trend with the significance of the surrogate endpoint led to thinking that it was at least somewhat promising that this would succeed in a phase 3 trial. Another design that comes up sometimes in phase 2 is what's called a selection design. This is kind of an unusual design, and the way selection designs work, it's not so much a hypothesis testing framework, as it's more of a, as the name suggests, a selection framework, where you could think of this like a horse race. And this is really kind of done to help with the pipeline problem. In other words, if you have resources where you want to do a phase 3 trial in some disease area, and maybe there's 3 or 4 potential candidates, and you don't have resources to do clinical trials in all of them, maybe your early phase study will look at which of those 4 candidates is most promising to look at in a phase 3 clinical trial, and you basically run some study and you look for which one of those is the most promising in whatever endpoint that you look at. You can have a placebo group to compare to if you need to meet some threshold in relative to placebo, but it's in essence picking the winner out of those. We recently completed one of those with Alex Vadinovich from Mass General in Parkinson's disease. This was looking at light therapy to treat sleep problems in Parkinson's disease. And it was a relatively complicated design where it had 2 interventions and 2 controls. So the 2 interventions were once or twice daily bright white light therapy. And then there were 2 controls, once weekly bright white light therapy and twice daily dim red light therapy, where both were thought to be controls. This had a go criteria where basically if either of the two intervention arms was better than both controls by, and 1.7 was the amount, which was 50% of the MCID. There's a lot that got to that point. But basically, if you met that criteria, then you would select one of the two doses. Okay. What we found in the study, it actually met the no-go criteria because it fell in this range where actually what happened was both of the intervention doses beat the one control, the once weekly bright white light therapy, but did not meet the other control, the twice daily dim red light therapy. So this is one of those, so one of the things I tell statistical students and colleagues, and Megan's probably heard me tell this many times, as a statistician, at the end of the clinical trial, your amount of work is inversely correlated with how happy the clinician is with the result you give them. If it's a positive, statistically significant result, you're going to the paper. When it's not statistically significant, you're doing lots of analyses to try to figure out why. Right? And so with this no-go, that's one of the things, and actually this is a study that opened up a lot of questions that we still haven't completely addressed. So part of the question is, and it wasn't that the treatments didn't work as you thought they would, it's that the control didn't work like we thought it would. And so part of the questions that come up from that, red light therapy was thought to be more inert than bright white therapy. But the question was, is there some effect of twice a day versus once a day? And is it the fact that you're doing the dim red light therapy twice a day that's giving you some benefit, perhaps, that makes that not a control? That's still being debated, still being investigated, but it's an example of a case where the study met the no-go, so you couldn't go to the phase 3, but it didn't really kill the line of research. It actually opened as many questions as it addressed at the end of the study. And our statisticians did a lot of exploratory analyses with that study that were important to do. Another one, and I think a couple of you at least mentioned, futility design. So that's good to hear that we're using that. The one thing I will say about futility design is if I could go back in time, I would change the name. Nobody likes the name futility design because nobody wants to do a study to show futility for what they want to do, even though it has an important concept. You could also call this a non-superiority design, which is probably conceptually a better name, because what you're really looking for, so typically the way I always explain this to our biostat students, with a typical hypothesis, you're trying to show that something is better. If it's not better, it could be worse, or it could be in this range where it's not really different. With a futility design, you're basically okay if it's better or in this range where it may or may not be different. You're trying to determine, is it clearly in this range of worse? And if you can show it's not in this range of worse, that's a justification to go to phase 3 to try to determine, is it in the better or is it in the not real difference, right? That's what we're trying to do. We don't really want to show that it's futile, but if we do show it's futile, we really shouldn't be going to phase 3. And I believe UCO years ago did an analysis in stroke studies that showed many stroke studies that did not meet their objectives in phase 3 trials would have met futility if they had a futility design in the phase 2 space. So again, it's not necessarily what you would want, and it's not ideal for you as an investigator who really wants your intervention to work, but it's good for the field as a whole. The earlier you decide that this doesn't work, then you can invest your time, the field can invest the resources in other areas. So that's the main objective of a futility design. They have high negative predictive values. If you reject the null for futility, it's very likely that your intervention doesn't work. It doesn't have high positive predictive values. Not rejecting futility doesn't imply that your drug works. Just like in the typical analysis, not rejecting the null doesn't mean that the null is true. It just means you don't have the effect that you saw. We did a futility analysis in myasthenia gravis with Richard Nowak from Yale that looked at futility based on where the endpoint was prednisone sparing, because you reduce the dosage of prednisone by 75% or more over the course of treatment, where the way this is typically set up is you kind of say, what is the effect I would need to show in a phase 3 clinical trial? Like, what would I power it for? So in this case, it would be a 30% increase in the favorable response rate. And so your null hypothesis here is that the active group, in this case it was rituximab, is better than placebo by 30% or more, versus an alternative that it's not, right? So from here, if you reject the null, you're saying this difference is significantly too far from 30% benefit that it's not highly likely you're going to see a 30% benefit in a future trial. If you don't reject this, you may or may not see this. And so with the go criteria was basically that you don't find futility, and your no-go is that you do. And in powering it, you kind of look at this, and this illustrates the one point that I was making earlier. If you assume the placebo rate is 40%, then this kind of illustrates the benefits of a futility design. This is the power, where the power here is the probability of declaring futility, okay? So you can see here, if the rituximab rate is at or lower than the placebo rate, you have high power, which means you're going to reject the null, you're going to declare futility, and it would tell you not to go forward to phase 3. If the drug had 30% or more effect, it has a 10% or less effect, where 10% is the type 1 error that we were using here. If it's somewhere in the middle, you have this range where you may or may not reject. But that's kind of the whole point here, right? The idea of the futility is, can you determine, are you in this range? If you're not in this range, the phase 3 trial would assess whether it actually works or not. So it's a way that you can actually do phase 2 trials with the same endpoint that you would need for phase 3, but in a way where it's more rigid, that it's not just an underpowered phase 3 study. This actually met the no-go criteria, basically because you can see here the two groups were kind of on top of each other. There really wasn't much separation here. So phase 3 did not go forward. A couple of other things that are common in phase 2 run-in designs. This is common, so there's several of you in the headache field. It's pretty common in headache studies. So, you know, we've actually done a headache study. We're doing another headache study, so shout out to the headache people. But, you know, placebo effects are a huge problem in headache studies. And so a lot of times the run-in are used for two things, to try to minimize the placebo effect, but also headache studies typically require headache diaries. And if somebody's not going to complete the diary, it doesn't do you much good to randomize them into your study. So you can tease both of those things out, where you have kind of this screening period, then you randomize. Another thing that's common is open label extension. This could be a fascinating debate of the ethics of open label extension. There's lots of good reasons to do it. But if you truly believe in equipoise, you probably shouldn't be doing open label extension, because there's equally likely that it's harmful versus benefit. But many people do it because it helps enrollment and so forth, and patients want access to the drug. I bring these up because we recently completed a study that involved both of those, and this was kind of a complicated framework, in Fragile X syndrome with Liz Berry-Kravis at Rush, which was looking at this hypothesis that if you had this, so it involved this intensive language intervention, but the hypothesis was, if you had this drug, which somehow helps you to focus, that kids who are on the drug with the intervention would do better than kids who just get the intervention but not the drug. So the way this was set up was there was this run-in period where they all started this placebo lead-in period where everybody got placebo. Then they were randomized, and then they started the language intervention period, and then basically how their change in their language over time, or their language ability over time, was the primary endpoint. This involved, the way they assessed this, there were structured and unstructured play periods where investigators would observe and score the kids based on how they communicated during those play periods. This was also done during COVID, so there's some challenges in terms of that, because some of these involved the kids playing with toys and there was problems with touching. One of the things was blowing bubbles, which was not a good idea during the pandemic, so that had to be modified halfway through. So it was relatively complicated. What we found was kind of interesting in the sense that neither the primary nor any of the key secondaries showed any benefit on drug, which went counter to what a lot of animal data suggested it should have done. In fact, the thing that was fascinating, it was not statistically significant, but every single one of the endpoints showed trends that were in a better direction on placebo than on drug. So not only did it didn't work, it clearly didn't work, because it wasn't even like you had trends on drug. It was going in the opposite direction. And I will say, I went to the Fragile X Foundation meeting where this was presented, and I have never seen a patient group accept negative results as positively as they did. They were happy to see this study done, because one of the things this did, there had been a number of other studies that had problems, trying to show that this worked, because there was such strong evidence on animal data. And this study kind of put the nail in that coffin, in the sense that this is not a good model. The animal model is just not predictive of what it's doing in humans. And I think that was important to the field, where they're kind of like, okay, we can move on to something else, and kind of accepted that. And that was really one of the big things that came out of that. It was a, quote, negative study, in that it didn't show the intervention worked, but it really answered the question of interest. And so it was a positive study in that sense, that it really served the purpose that it was intending to do. Another study that had a different complicated design was a study we did in cryptogenic central peripheral neuropathy that looked at kind of two endpoints. One that was quality of life, and one that was based on nerve function. And kind of the go criteria here was that both had to meet non-inferiority, couldn't be worse than placebo, but at least one had to be better than placebo. What we found in this one was that both were not inferior, but neither of the endpoints was better, right? Again, like I mentioned, study didn't give results, so the statisticians do extra work to look at that. And this was another one that opened a lot of questions. Because if you did the per protocol analysis, where anybody who dropped off early, didn't receive drug and so forth, had a major protocol deviation came out, we actually would have met the go criteria. So under the per protocol, you had the case where the INEFD, the nerve function, was significantly better, whereas the INQUAL had non-inferiority. You would have done that. When we look deeper into the data, again, this is one that opened a lot of questions. These patients were getting topiramate, right? Those of you on headache are familiar with topiramate. There was a lot of what the adverse event was coded as cognitive decline, which sounds horrible. But it was basically like, when you dig into it, it was kind of feeling, a little, what I would call loopy, right, in a non-scientific term and stuff, but it typically resolved in a month or so, and it's not unexpected with topiramate. So what we found was, and we parsed through all the different reasons people fell out of the protocol, but basically if you left those people out, so you looked at those who tolerated the drug, then you would have met the go criteria, right? Now that's not strong enough from the study. But in hindsight also, then the question was, if you could redo the study and counsel people better at the start, that this is an expected side effect, if you can deal with it for a few weeks, it will go away and you will see big benefit, maybe this would have been successful. So again, it's one where it was no go, but it didn't really kill the line of research. Two of the studies we have ongoing both involve industry partnerships and involve somewhat different information. So one is a study in GNE myopathy, which is a relatively rare disease, looking at whether the intervention can slow the progression of muscle strength decline relative to placebo. Since this is rare, one of the challenges in doing the studies is you would typically need larger sample sizes than you could typically enroll in a study like this. In working with some colleagues from Berry Consultants, Melanie Quintana in general, the study is using a disease age progression model, which is able to use kind of Bayesian model, a lot of complex modeling, to look at the different muscles and give you a disease age, and then look at whether you're kind of slowing the progression from that based on the model. And in doing so, that led to the ability to be adequately powered based on this disease progression model with only 54 subjects, as opposed to if you use the more standard clinical models, you would need twice or 3 or 4 times that. And so it made it somewhat feasible. We finished recruitment. We have actually recently finished in-person follow-up visits. We're doing the follow-up AEs, and we expect by the end of this year we'll have the results for that study. There's also the, in 111, the Extinguish study. This is with Stacy Clardy at Utah. If any of you have seen Brain on Fire on Netflix, this is that disease. So it's a pretty brutal disease. The endpoint here, so it's a relatively straightforward design. It's not a relatively straightforward study. But the endpoint is actually interesting. We're using the MRS but we're not really using the MRS. We're using a modified Rankin scale because it's the modified Rankin scale modified for a G&E myopathy population as opposed to a stroke population. Both of these are rare diseases. Both of these are phase 2 studies. But some of the challenges in doing that in a network like ours is we're funded to do phase 2 studies. And these are phase 2 studies, but they may not be phase 2 studies, right? So part of this is, you look at the Scooby-Doo, if the study is negative, it will always be a phase 2 study, right? Which is what it's funded at. If the phase 2 study is positive, there's a high chance it then becomes a registration trial at the minute it's positive. So from the network side, we have the funding and resources to do phase 2 study, but we also have to have in the back of our minds, we have to have a lot of the rigor that you're going to need for a phase 3 study if this goes forward, because but you don't want to necessarily go all in on that because if this doesn't work, it will always be a phase 2 study. So as I call these using my Southern English, it's phase 2 till it ain't. And so we'll wait and see. So that's just kind of a high overview. I'm glad to talk to any of you more about specific designs or experience through NeuroNEXT. I mentioned the 2-stage application process. There are links here. There's the QR code here. I believe the slides will be shared with you on the box after this. And then Lumi, who is in the back, is the contact person if somebody has an idea for NeuroNEXT. So again, we encourage applications, particularly pediatric applications. We're looking for pediatric studies, but we're also looking for any kind of studies. If it's a good idea, reach out to NINDS. If it's something that they agree is good, then you can start the process through the network. So, that's all I have. Again, look forward to talking to more of you later. You have a question?
Yeah, and I think it's, as a biostatistician, I often, people will say, well, we can use a biomarker instead of some kind of, dichotomous outcome.